Compression is for what? IT band. So just bring the patient's leg up, bend the knee, bend the hip, everything at 90, pivot to the superior pretty much, put pressure right around the condyle of the femur, and bring the leg down. That causes them pain, IT bands, right? And of course, always say what? Where? And always do the test bilaterally, beginning with a good side. Okay?
Slocum.
What's the next test? Slocums. Slocums, that's for anterior, medial, and anterior lateral rotational instability, right? And I know there's a lot involved with that. Just remember those two. I'm very happy with that. Anterior lateral rotational instability, anterior medial rotational instability. So if you have the leg is rotated internally, that's for anterior lateral rotational instability. Okay? Because whatever's pointing at you, you can see as you rotate the leg internally, that's what comes out more, the anterior lateral portion. So you stabilize, give it a nice steady yank. You're looking for this to move. You can even palpate again, just like you do with the anterior drawer along this tibial plateau, and you're again looking for laxity, pain. He always asks the patient where. Laxity indicates at least a grade 3 tear of the anterior cruciate, but there's a lot of other things involved. Okay, and anterior medial, you're just going to put in external rotation, and you're going to then pull it. Watch when you're pulling this that you're not pulling down here. Make sure you get up above that calf, and at the distal portion, or the proximal portion of the tibia, and pull forward. Okay? Don't pull in the calf. What's next?
Apprehension test.
Patella apprehension. You're just going to move the patella, right? Look at the patient's face. And you want to move it medial, you want to move it lateral. Okay? And if there's no apprehension on the patient, then everything's happy. Wilson's test, that's osteochondritis dissecans, right? That's when you turn the foot, and the patient, this is another one of those, turn the foot, bring the knee up to 90, the hip up to 90. This is an active test. The patient's going to actively push on this one. You're going to have the leg, again, internally rotated, and the idea is that you're putting pressure on that lesion with the tibial tuberosity, right? So we're going to go like this, or tibial tubercles, excuse me, like this. And then the patient pushes, and as they're doing that, it should get about here, and they say it hurts, then you should be able to relieve that pain by turning the foot back into a neutral position. That's Wilson's test. There's a Wilson's test for the eye, too, isn't there? For some reason I'm thinking, what is that? Wilson's disease, is that? Copper. It's copper. And you can see it in the eye, is that what it is? What do you see in the eye for that? I don't know.
Was it on boards? Flapping tremor.
So what do you see in the eye again?
Ring around the iris.
Oh, ring around the iris. Okay.
Brows ring.
And what does that mean, that they're not, why do they have it?
Like a streak.
Inability to get rid of it.
The lead poisoning does the same thing, but a lead color.
Plica.
Hughston Plica. What is Plica?
An extension of the synovial capsule.
Extension of the synovial capsule. Should have gone away, what is it, in the first trimester of development, second trimester of development. And so it doesn't, and then something causes it to thicken, and then it starts to get trapped between the patella and that medial condyle of the femur, right? So we're going to bring the leg up like this. We're going to internally rotate the foot. We're going to add some valgus stress, but not on the knee. It's really not valgus stress, I shouldn't say that. We're going to push the patella medially, okay? And as you're pushing the patella medially, you want to palpate along here. Some people grab it like this and push it. Some people use the heel of their hand. I don't care how you do it. But you're supposed to palpate along here. And as you're doing this, and I'm putting that pressure on there, you'll feel that kneecap move over. And as that's happening, you're trying to trap that plica within there. If it does, the patient, what's the symptoms? Pain?
Snapping.
Pain, snapping, or pain. Okay. Now, is the snapping painful? Doesn't say. Okay, snapping or pain. Okay, Hughston Plica test. And that's what we're trying to do. We're just trying to trap the plica between the kneecap and the femoral condyle.
Anterior drawer test. Posterior drawer test.
Anterior and posterior drawer test. We've not done that?
For the ankle.
Oh, for the ankle. Okay, let's have you bring this leg up like this. Anterior and posterior drawer of the ankle. We're looking for that anterior talofibular ligament, right? And so if we're doing an anterior drawer test, whichever way you're moving the talus is where the problem is, right? So if I grab on here and I push this way and pull, I'm looking for that translation to take place. If it's a posterior drawer, then I'm just going to do the exact opposite, push the talus backwards, right? And what's the name of the joint between the talus and the tibia? Mortis joint. Mortis. Some people say mortis, huh? Some guy said mortis. What's that?
That's how I pronounce it.
Mortis. I just call it the mortis joint. No, I don't know. Okay. I don't know. People say all kinds of whatever. Thompson's test. Thompson, that's when the patient's prone, right? And what are we testing for? Thompson's has an AKA, right? By the way, what's the AKA for Alice's test? Good, good. So we're going to bring this up. Thompson's test, we're looking for integrity of the Achilles tendon. If you see this here, they're good, right? If you don't see that, they're not good. But what you can always do is you can just take the patient still and just do this because it's fun, right? And not so much at the proximal portion. You want to get down lower on the calf. You can see that moving. You can do it seated if you take the patient and you have to push the foot into dorsiflexion and hold it there while you're doing it so you can feel the contraction. Right? Because you do it seated and you're not holding that back, you may not see it because the foot's just going to relax in that plantar flexed position. So if you're going to do it seated, let me have you sit up for 1 minute. You never know how they're going to have you do this. So and let's just say he's on a higher stool or whatever. When you're doing it, you can't just go like this because you may not see. So you have to take it like this, and then you can feel. Okay, and you do one, and you do the other. Okay. Okay, and that's for Achilles tendon rupture, integrity. Good. Next.
Medial and lateral stability.
Medial and lateral stability. Medial stability, we're testing what ligament? Deltoid lateral stability, we're testing what? 5 fibs, right? Primarily the anterior talofibular, I think is what they taught. But remember I told you anterior and posterior talofibular. What's the other 3? Anterior, posterior tibiofibular, and the calcaneofibular. Just remember that. Kind of easy, right? So we're going to take the patient's leg. We're going to then just pull the patient's leg over like this. You want to get up on the, in fact, you should do this with the patient's shoes off. Make sure you're grabbing a hold up here, as much on the calcaneus as you can. Get up deep in there and pull this over this way. Then you're going to do it this way. And this would be for lateral stability. This is medial stability. So try to yank all of those carpals, all those tarsals out from underneath there. Would be a good idea. So if you can even influence the talus, I think it'd be a good idea because it's the talofibular ligament.
You're just holding it this way.
Yes, that's all you're doing. Just pushing it back and forth. Did we do Buerger's test?
It's on our notes.
Okay, how do you do Buerger's? I mean, we're in the ankle, and I don't remember doing those vascular problem ones.
I think we talked about it. You said you don't remember doing it.
No, you do Buerger's. What is Buerger's? You're going to hold the leg up like this, right? And you're going to look for blanching or discoloration, changing in the foot, etc. You're going to hold it there for like 3 minutes, and you're going to look for changes. And that's some type of vascular problem, right?
Yeah.
The other vascular problem is for like DVTs or for thrombophlebitis, and that's Homans, and that's one we don't ever squeeze the ankle on that. Some people I see, if you follow them on YouTube, they'll just do some extension of the foot and see if that causes some pain in the calf. And then if the person's within that range, like generally a little bit older person or whatever, then they might just refer them out. And the first thing they refer them out for is what? What do they look for that? How do they look for it? With what? Doppler ultrasound, right? They're going to just go up
Will
and
you
down.
be tested on Homans?
No, I just want you to know that you're not going to do Homans. Okay. Who was it tell me in here that there was a chiropractor down there? Morton's neuroma. What are we going to do with Morton's? We're going to squeeze the tarsals together, right? Side to side. And as you crunch them together, and of course the patient does not have shoes on. You crunch them together, you're looking for what? Pain. And where's that pain going to be?
Second and third.
Second and third, yeah. Now, you know, a lot of things cause pain. Patients never say to you, oh, that's a false positive. You know, they don't do that. They just say, that hurts. So it could be like a metatarsalgia. It could be a compression, a stress fracture. What type of, there's two types of stress fractures, aren't there? What are they? Fatigue and insufficiency. Remember that? Fatigue and insufficiency. What's a fatigue stress fracture?
Too much use.
Too much load on a healthy bone. And what's insufficiency fracture? Normal load on a weak bone. Okay. Remember talking about those? Yes.
You said second and third, and you said third and fourth, so do we change that to second and third?
Well, I'm sorry, I was coming from, no, it's third and fourth. Between third and fourth. Yeah, I was looking from the lateral side in my brain, and I just said that. I'm sorry.
No, on the test that doesn't require shoes, do you want us, when we do the practical, do you want
Yeah,
us?
you got to take the shoe off.
Okay.
Yeah. You guys may even just want to come in for this test, you know, just in your bare feet. You know, or socks, stocking feet or something. And if you could wear shorts, it would be good. Because all these tests, you are supposed to be looking at that person. You're supposed to be looking at that. Because if we're looking for this translation and so on and so forth. So probably when you go into part 4, your patient will be sitting there in exam shorts or so on. So you just get used to doing things on skin. And it's better for you even in your office, you know. If you're ever questioned about doing an orthopedic test and they ask you how it was performed, and you had pants on the patient, long pants, and you did the test, and you said you got some type of XYZ result, they're going to ask you how, you know. I think one thing we need to have is, sorry, I'm distracted. I think we're done. Oh, we're done.
What about the ankle sprain grading? Will you be
Ankle
asking?
sprain grading. Oh, I could ask you questions. It's just patient just comes in, they're weight bearing, but it's a little bit sore. Then it's what? Grade 1. They're hobbling in, you know, depending on how much they're hobbling in, but they're on their own ability. You know, limping, maybe even a severe limp. It's still what? It's a 2. And if they can't bear weight at all, and somebody's helping them, they can't move their leg, etc. That's a grade 3. Okay.
What are the type of questions you're going to ask after the exam?
What type of questions am I going to ask after the exam?
After you do the, you know, like peripheral nerve, just, is that it?
Yeah. You mean tomorrow? The practical is just going to be like the first practical. Orthopedic test on the lower half, but the disc lesions will be cervical and